Hello everyone, I'm Dr. Darsh Shah.
And I'm Dr. Altamash Raja.
And welcome to Medicine Redefined,
a podcast where we will explore the often overlooked but necessary components of health, what we consider to be the fundamentals.
We will investigate topics and practices that can give you and your patients the best chance to optimize a healthy lifestyle. It's time to move the needle forward and put the health back in healthcare. All right, what's up everyone? Back for another Lessons Learned cardiovascular series here. Going over these 3 episodes with 2 guests, Dr. Nicole Harkin and Dr. Alex Hajduczok. So let's start with the first episode, which was Nicole Harkin. So we talked about essentially cardiovascular disease, as a concept, and also understanding it from a standpoint of the physiology. So I should say the pathophysiology, as well as kind of like consumer tests that we should be looking at to assess risk for cardiovascular disease. And I know you would have been a cardiologist if you had a second profession, but I think right now that'd be a little tough. But tell us your thoughts.
I really enjoyed it. I think it was really informative. I think partly because it kind of aligned with my biases from the research that I had done. And, I had some time to reflect since I had the discussion, actually, and went back and listened to it. As I had mentioned, over the last couple of years, I've gotten more and more invested in this space, both for personal reasons, but also from an academic standpoint. And I think she was actually the 4th or 5th cardiologist, and maybe the 3rd lipidologist that I have a conversation. And 2 have been kind of, okay, well, ApoB and these things are maybe advanced markers, and we don't have, the science isn't quite developed yet. Another person said, oh no, I mean, this is very much so, and there's a lot of nuance to it. And then with her, I think she kind of echoed that sentiment that there is nuance to it, and there's a place for it. And then with some of the guidelines, at least across the pond, seem to agree with that sentiment as well. So that part, obviously, I enjoyed. But I think it really just kind of comes back to really what lens we're looking at the problem from, right? And I think that's the case with anything when we do this whole like health issue. She's looking at it from a preventative standpoint, and medicine largely isn't that at all, which is our beef with a lot of it, of course. And I think that's why, I always have to appreciate that as still a novice in the field of medicine, is when I'm having these discussions with these folks who've been doing it for 30, 40 years, and they're definitely wiser than I am, that we haven't been trained to prevent disease, prevent illness, and prevent all these major adverse cardiovascular events that we talked a lot about.
Yeah, for sure. I'll add on to that. So I come from the standpoint of I hated cardiology, in med school. I just never understood it. It was way too complex. I always thought about cardiology as just the heart. And obviously, this episode kind of opens your eyes to, wait, there's also a vascular attached to that, right? Like blood flow. And I think the cool thing about cardiology for people who really truly want to understand it, it's almost like, I'm trying to get into F1 as of late, right? Just because there's a huge boom about it, but it's also because it's so in depth. There's so many different ways that you can look at it. And that's exactly what cardiology is. It's the how, right? It's the pathophysiology. It's the when, which is a huge discussion when we talk about preventative cardiology. The what, right? If we're dealing with the heart, we're dealing with blood vessels, we're dealing with plaque. The who, are there different populations? What's the genetics? And the why. Why does this all matter in the end? And that's because obviously cardiovascular disease is the number 1 killer. So I think taking all those into consideration, it really makes sense, especially as us physicians, when we look at our patients. And obviously from a rehab lens, I mean, which patient doesn't come through with cardiovascular disease? I mean, I'm always seeing high blood pressure, CAD, heart failure, et cetera. So I think from that lens, for people who, I really urge people to go back and listen to this, because it's going to change your perspective in terms of how cardiology probably should be looked at and what it will probably be looked at in the near future. And for me, who I'll admit it, I haven't seen a physician in a while, ever since moving to Hershey. So I should probably get on that. But one of the things I need to test is ApoB, right? And I was just listening to a Peter Attia podcast, taking notes, and he talks about how ApoB should just be the one thing that everybody should frequently get. And his ceiling would be at a 60. So he's very aggressive when it comes to treating, and he wants people to be in the 5th percentile or below. And he's thinking everybody in their 20s should be getting this test. is how early you should start and actually when you should probably be treating. Now, I mean, that's going to differ from provider to provider, obviously, but as we know, Peter Attia is somebody who really, really digs deep, has a research team, and loves talking about this stuff. But I think that's kind of the perspective I came with from the first episode.
Yeah, and I think that's one that she mentioned several times that it's somewhat controversial. And to me, I'm not exactly, I mean, yes, the arguments have been made. Some of them we brought up, right, cost or not clearly being defined and whatnot, how to target it. To this day, the standard lipid panel, right, checks LDL. What some people will say, we talked briefly about this, non-HDL cholesterol tracks ApoB pretty closely. And I mentioned some of the cardiologists who we talked to who were not really naysayers or dismissed the profound benefit of actually checking ApoB. And their argument was, well, you can just really get non-HDL and that's a poor man's ApoB. And to me, I don't really know why we need to get a poor man's ApoB if one, we can just get the ApoB and two, like insurance will pay for it or I will pay for it. It's fine. But anyways, that's a different discussion. The bigger point with that argument though is, man, we also talked about how in a perfectly healthy person without any of the metabolic syndrome markers, which we touched on, that a study came out a couple of years ago that like 88% of Americans have that, maybe non-HDL is a good marker. And there's about a 0.9 correlation. But again, the key phrase there is perfectly healthy person, like no metabolic syndrome markers, right? And that, how often do we see that? You just mentioned people come in with actual heart disease. And I would say if it's not that, it's risk factors, right? I think during the episode, you talked about how almost every single person's on a statin. And that's either for, like empiric treatment for, cholesterol issues, dyslipidemia, whatever it might be, which are risk factors for cardiovascular disease, or it's protective, right? For heart disease or stroke or whatnot. So, I mean, I would say at least anecdotally, greater than 95% of patients that I see, both on the inpatient and outpatient setting, are, have some form, either predisposition or actual heart disease for that. So why we wouldn't check something that's going to give us the best data and allow us to make the most informed decisions? I think that's a little bit over my head. There were a couple of other things that we talked about as well, right? Well, actually, I'll pause there.
No, I was going to say, go ahead, because I think my final thought was going to be this episode will give people the power, hopefully, to approach their doctors and get the test necessary, or at least inquire, right, about these tests and have a great discussion.
Yeah. And I think, so it was a two-part series, right? And I asked this important question about how to actually approach our physician, our providers, our cardiologist, and actually have the conversation about, hey, what are some of the important risk stratification markers, right? Whether it's LDL particle number, particle size, it's another one that we talked about, some of the advanced lipid panels, ApoB, Lp(a), how critical that is as well, how the European guidelines recommended that every single person should have it checked at least once in their lifetime. You brought up Peter Attia. He also suggests that this might be the most atherogenic particle, and I think he's not the only one who'll argue that. And I think there was a study that I remember coming across right before we talked about that up to 50% of aortic stenosis are, or Lp(a) is responsible for up to 50% of aortic stenosis. So, and then we also have, DVTs and thrombosis in that nature as well. So I think that there are a lot of different markers that people should be aware of for themselves. The caveat is going back to what are we going to do with the test, right? We talked about ApoB is something that you can target just like we can target LDL. So I think that's a no-brainer. LDL particle number and particle size, to my understanding, may be a little more challenging in terms of using as, targeted therapy towards those. But they're still important because coming back to that metabolic syndrome, point, if somebody has that, the discordance tends to be higher between LDL particle number and LDL-C concentration, which is usually, taken in a lipid panel. And in those individuals, the risk tracks closely to the particle number. So that's something that every provider who's actually checking this, whether it's a PCP, us in the rehab setting, needs to be cognizant of.
What does discordance actually mean for the people out there that say, what is that?
Yeah, that's a good question. Yeah. So if your LDL-C is high, right? So it's traditional LDL, and your LDL particle number is also high, that's concordance, right? If they're both high, not good. If they're both low, good. But if LDL-C is high and LDL-P is low, that's actually better than if LDL-P is high and LDL-C is low, right? And so individuals who have some metabolic syndromes, particularly high triglycerides, they're going to have them going in opposite directions, which is basically what discordance is. And when they do go in opposite directions, LDL-P is the number that you're more concerned about. And so that is really, really important to understand. So I think that, fortunately, we don't do a lot of this. I'm not going to do a lot of this in sports medicine, but looking at a person taking a step back and that 50,000 foot overview and looking at their lifestyle factors, I very well might order this test. And I think that this is the conversation that we're going to start having. And then it's not a blanket statement. I'm not going to order it probably for every single person. But I think that, when we're looking in front of, if it is an individual with a higher BMI, waist circumference ratio, like you talked about, or any of those other metabolic syndrome markers, then maybe one might be more valuable than the other.
Yeah, for sure. Yeah. And overall, again, I just think it was an awesome episode. Dr. Harkin, she knows the data. She knows her stuff. Like, she's not just talking as if, from out of thin air. I mean, this is stuff that she's looked up, done the research, as any cardiologist would. Well, I shouldn't say that, as hopefully most cardiologists should. But yeah, it's just a great episode overall. So how about you want to transition to that second episode now, kind of talk about the interventions?
Yeah, but before we do that, I think I do want to mention briefly that even though we spend a lot of time looking at objective markers for risk stratification, something that really should be emphasized is just history. Every medical student knows this, how important that is. And she talked about, even before somebody comes to her, the intake process of how in-depth she's going into personal medical history and family history, how important that is. I don't know. It's hard to say which one would be more important, but I think that's just as critical. So knowing your own medical history and your family history and really digging back, I think that's also very, very important. So I don't want people to be like, okay, I want to go get the test done, but you haven't done research on yours. Like, you have no idea, like, if your mom has this or your dad has this, if there's any premature history and your grandpa died before the age of 50. So I would urge people to do that, because that's much easier to do and you don't need a physician to do that. And that might give you a lot more information, and you don't have to fight anybody to get that done. So that would be the little bit of advice. Not medical advice, just advice.
Right. No, that's very true. So, right, we're talking about genetics there, and now the second episode, I guess, is talk about how to influence your epigenetics, so to speak, which is huge, right? And Dr. Harkin is a preventative cardiologist. That's her main practice now, and so she really delves into kind of the lifestyle medicine aspects, looking at those pillars, looking at the history, like you said, and trying to put better intervention out there. For patients to stabilize and not, reversal is great if it could happen. And, we talked about this, but stabilization, I think, is what most people care about, right? Because we want to look at adverse events. And if what we're trying to do is prevent another myocardial infarction from happening, or preventing a stroke from happening, right? But if the plaque stabilizes and that's the result of it, then awesome. We don't really care about the plaque receding so much. So I think that's like an important thing, right? Because when we talk about longevity and health span and lifestyle medicine, a lot of people are in this mindset of reverse, right? I think that's just the society we live in. We want to gain more muscle and reverse the fat. We want to reverse aging. We want to reverse, et cetera, et cetera. So I think that right there is just kind of an important fact that people need to take note of.
Yeah. And that's really interesting that you bring that up. And I think you kind of alluded to this during the discussion with her as well. And I think, I'm wondering why this is. I think partly it's because information is so readily accessible through social media, through Google, through everything like that. And people can read about procedures. Like, for instance, I had a patient come in and, she had bilateral carpal tunnel syndrome, and I'm not a surgeon, but I recommended that it was a point that she had a discussion with a surgeon to kind of get that addressed. And she started asking me in-depth questions about the surgery, kept telling her, listen, I know this is how it's done, but it's not what I do. And she mentioned how she looked it up, and this is what the post-operative course is supposed to be like, and all that kind of stuff. And it's interesting because you could probably see a lot of these things on YouTube now. Right? You can actually watch the procedures. And that might be the case when it comes to nutrition, of course, with cardiovascular and all that stuff as well. And so people are maybe hyper-focused on this aspect you're talking about. Can I reverse my plaque? I mean, that's cool and all, But does it
Right.
really matter if you feel like crap? Like if you get short of breath while walking
Yeah.
upstairs, like, is your heart functioning well? I don't know. Maybe you reverse your plaque. And so I think she talked about this. She's like, looking at quality of life is really, really important. And, I wonder if 50 years ago, before we had all these things that are so readily accessible to us, if people even
Right.
cared about that.
That's true.
You know what I'm saying? So
Probably more
maybe
of a focus on quality of life.
the outcome that we're looking at. Yeah, exactly.
Yeah, absolutely, for sure. Cool. So let's talk about some of the lifestyle interventions then. Which are the ones that kind of got you excited, that you learned something new about?
Yeah, I think it was no surprise to me that she started to tackle with the nutrition thing. I think, we took the lifestyle medicine approach, and nutrition is the most polarizing. And again, I've been thinking about, if I had to pick one, right, that I would want to start like implementing. Of course, I know the right answer is, it's really about meeting the patient where they're at. Like, hey, if they're open to having a nutrition conversation versus exercise versus sleep or whatever intervention
Is this
it
for
might
heart?
be.
Is this for cardiovascular disease, you're
But
saying, to start one?
good question. For
Okay.
the lens,
Okay.
yes, for cardiovascular disease specifically, right? I wonder if exercise might be an easier place to start. I know we talked a lot about plant-based diets, about how they are, for lack of a better word, cardioprotective, if not definitely beneficial for long-term heart health. But man, I think the more I do this, the more I have conversations with people, it's hard. It's very, very hard to do.
I'm in the same boat, man. I would start with exercise, because it's not everyone knows it's helpful for you in some way, shape, or form. It's going to be beneficial, right? But to get people to buy in to eating more plants or eating less processed food, the results just aren't immediate, right? And I think, again, we're talking about a society where if everything's at your fingertips, we're just gravitating towards quick remedies, and keeping up with a diet that's helpful is tough, right? And that's why I guess, like, I'm a fan of these objective markers, because in a way you can gamify it for patients and be like, all right, your ApoB is here, like, let's try to target it next time to a lower, and the only ways you can do this are by X, Y, and Z. Well, not only ways, but here are some ways that you can do that. And so I guess it gives patients a little bit more motivation. But in the end, man, I mean, nutrition is just, oh man, that's tough. That's a tough thing definitely to talk to with patients, especially in the healthcare system we're in, right? I mean, if you have an hour and a half, awesome. That's you can probably start with that, which is what Dr. Harkin probably does at times, right? Because she has that time to do with her patients. But yeah.
Yeah, I think, and we talked about exercise from an aerobic versus anaerobic perspective, right? Or strength training versus cardiovascular exercise, but really about movement. And you and I have talked about just getting up, getting steps in, and just walking, how important that is. I actually came across a study. I was looking at Examine earlier today, and there was a study published in a Sports Med journal in February of this year, looking at the acute effects of interrupting prolonged sitting time in adults with after postprandial, and what that did to the postprandial glucose response. Exactly. Thank you very much. And they compared essentially sitting for after you eat to just standing, sitting to just light intensity walking, and a significant benefit, right, in terms of decreased glucose response. Of course, the question becomes, well, how high does your glucose get after? But I'm willing to bet it's not harmful in any sense, right? So I think that's another important thing to keep in mind. Is just what's your NEAT, right? Non-exercise activity thermogenesis throughout the day. How much are you moving? There's the next guest that we're talking about, Alex, referenced a study in BMJ, I think that was published last year. It's a meta-analysis looking at just step count and overall cardiovascular health, and all-cause mortality decreases, I think, anywhere from 10,000 to 16,000 steps a day, like down like 17 or 18% for all-cause mortality. So it's just really about getting activity in through the day, And so when I think about incorporating these interventions into lifestyle, rather than saying, okay, I do like E.C. Sinkowski's, let's get more plants in a day. It's simple messages like that. But also, let's move for 2 minutes after you eat. Something like that, I feel like that's easier to buy in. Food's hard, man. There are so many emotions and psychological factors that are associated with what we put in our mouth. That's a little bit more challenging.
100%, man. And, just to dovetail on the on the movement aspect, I mean, this is why I'm a huge fan of kind of Kelly Starrett and and what he puts out as content, because he's always just talking about easy ways to incorporate movement, right? From a mobility standpoint, from just an exercise standpoint. And, for those of you guys that are new to this podcast, I mean, we've had him as a guest. He's probably in the episodes like somewhere in the 30s, I think. But he just put out an Instagram post, I think today, just talking about like his, how he's sitting just doing work on the ground, and how he'll be like in a 90-90. Being a 90-90, and then on his knees, and then he'll be up on his toes and just moving his, just different movement patterns. And like, even that, just sure, it might not consider as exercise or steps, but if it makes you feel better, it's gonna have a chain reaction to at least make you maybe feel better about yourself, and then maybe go on that walk, maybe relieve some pain, right? So it just starts from somewhere.
Yeah, something that I remember Dean Somerset talking about a long time, maybe over a decade ago, is rather than sitting on the couch, just sitting on the ground. If you're sitting on the ground or you're watching a movie, like on the couch, you could sit there in the same position for 3 hours and be comfortable. But if you're sitting on the ground, like, you are going to want to change positions multiple times, because your bum's going to start hurting that ground pressure. So that I make it a point to do that as much as possible.
Sure. Absolutely. Same. Lacrosse ball, foam roll, or like just use my, what do you call it? The hyper ice, and just do something at night as if I'm watching TV or something. Yeah, for sure. All right. So anything else from that part 2? I mean, we touched on sleep. We did exercise, nutrition. For me personally, I asked her about sauna, because I just remember hearing like a bunch of podcasts being like, hey, the future of cardiovascular disease, like some of the therapy might actually be the sauna. And I don't know if you got the chance to listen to Rhonda Patrick's episode. I think it just came out maybe today or yesterday. She does a deep dive in terms of the sauna, and like, I'm gung-ho about it now. I mean, there's just a lot of good data that shows a lot of benefits through sauna, especially if you do it at least 4 days a week, from blood pressure to just the heat shock proteins, and helping with longevity, and just decreasing mortality, all-cause mortality. So,
yeah, and I think at least that what I'm aware of, most of the data, though, something to keep in mind is it's coming from, again, from the Finnish countries and from the European countries, right? And the second part is that is really looking at dry sauna, which it's harder to come by in terms of gyms than the infrared sauna. And most people will end up extrapolating that information and say for infrared sauna, you need to be much higher, like the 170, 180 degrees Fahrenheit, whereas dry sauna needs to be a lot lower. So again, with these research studies, when you're actually analyzing them, is the intervention a 1-to-1? I don't know. But I do agree. Much like anything else, there is a ramp up period. You can't just jump into 5 days a week, 20 minutes a day. Because I think the dose is, what do they recommend? You want to do 20 minutes, again, dry sauna, right? 20 minutes of a couple times a week, probably, to get the benefit that you're talking about.
The episode, but from what I can recall from previous listenings, I think it's about 20 minutes at least is kind of where you get benefits. And I think there's a spectrum too. So like, there's different physiological things that will happen in your body at 10, 20, 30, 40, 60 and onwards. But yeah, I haven't finished the episode yet. So,
Well, the other thing about it, I think Peter Attia again did an AMA episode with Bob Kaplan back in the day, looking at heat and cold therapy. And part of the conclusion they came to with that it's a good mimetic for exercise. And maybe some of the benefits that are conveyed are because of that reason, because just getting your heart rate up to 140 degrees for sustained 15 minutes, it's going to give you a lot of good benefits.
Yeah. You're almost getting in that zone 2 range without really doing any, like, you're not really short of breath, but yeah, absolutely.
Sparing the joints.
Yep. So yeah, for me, it's part of my morning routine, at least sauna. By my gym has a dry sauna, which has been nice. So yeah, cool.
Nice.
Awesome. Cool. What else? Anything else from that second episode?
No, I just encourage people to definitely go back and listen to both of them. I think that Nicole does or I should say Dr. Harkin, apologize. She does a phenomenal job at really just highlighting and kind of giving us where the evidence is for, again, both the diagnostics portion in the first part of the discussion, and then also at the intervention, aspect, and really giving us perspective and looking at the big picture. So I encourage you guys to go listen to that, and you'll be much smarter for it.
Absolutely, for sure. All right, cool. So our third episode is with one of my buddies, my co-residents from last year, Dr. Alex Hajduczok, who's made a name for himself as a champion of Whoop. He is someone who has done a lot of studies with wearables, and kind of their relationships with not only inpatients and just looking at different markers of cardiovascular disease, but also with resident wellness. So, I knew a little bit about this from beforehand, but for you meeting him for the first time, what'd you kind of take away?
Yeah, man, he's brilliant. It's so funny because he was really keeping that from the very get-go, just telling us how remote monitoring, the backstory of how it really started in the lab for him, taking that time between, time during medical school, getting his PhD, and then ultimately deciding that he wanted to get more clinical training, and that how that developed, and then his own personal training and looking at his recovery and sleep and the interplay with residency training, and how he was able to apply that to really turn it into for the better and create this wellness initiative essentially. And I'm excited to see what the data from that shows. Now, I didn't know this, so I know that. So you were a part of the study, but you're not going to be an actual N in the study because you're an internal medicine resident. Is that correct?
So I was a prelim resident. So I had a different rotation schedule because I didn't have to do ICU my intern year, whereas they did. Mm-hmm. So they brought us on just to get more kind of data, but will be used like separately in terms of rotation schedules and kind of just the endpoints.
Right. Maybe like a subgroup analysis. Yeah. Yeah, that's very cool, man. I think it's important, and so maybe you're not allowed to disclose this, but I imagine other than HRV, there are a lot of other markers. He kind of referenced that he looked at some subjective scores, burnout scores, and that kind of stuff
that's exactly
as well, right?
It. Yep. So we would do some screens. So we do like a PHQ-9, we do the grit score, and we do those essentially every 2 weeks, and then every month or two we do like a bigger survey with almost all of it. And then, they would be tracking our HRV for the most part. I don't think like sleep or anything of that, the journal, things like that weren't included. It was just usually using HRV and just seeing the trends with rotation.
Tell me this, knowing that you're being monitored like that, be honest now, reflecting back, did you change any of your practices?
No. I mean, I feel like a lot of the other residents, they felt like, oh man, I have to wear this Whoop. Like I have to wear something. Like it was, excuse me, it was difficult for some people to consistently wear it because they're not as a fitness junkie as I am, or, they're not so like geeky as we are in terms of tracking data and things like that. So for me, I thought it was awesome, but no, I kind of kept the same lifestyle I was living. Still going to the gym as I normally would. There wasn't really much change.
Yeah, I think there's something, I'm curious again to see what the data shows, but I'm wondering what the Hawthorne effect is going to account for, where as people know they're being observed, particularly those who everything that you just mentioned isn't a part of their routine, right? Going to the gym, getting good quality sleep, or getting just adequate quantity sleep, ICU or no ICU, doing things of that nature. I wonder if, and hopefully we'll be able to chat with somebody who was a part of it, actually part of the data that's finally analyzed, and see what they thought, from that. But I'm excited to see what it shows. And then more importantly, what we're going to be able to do with that. I think that he said, some of his hope is that program directors will be able to take this information and really evaluate whether the structure, at Hershey, you guys have that, but I imagine a lot of institutions have it. I mean, our ICU rotations were for 4 weeks as well. Probably a lot of variability in what kind of ICU you're doing, but you really have to question, do all these rotations need to be structured a certain way, or is there a better way? I mean, really, that's what it's all about.
Totally. I mean, I think when it comes to like the bigger institutions, right? I mean, there's like 20 per class in the internal medicine residency at Penn State Hershey, and rotation schedules can be a tough thing when you're trying to figure out 60 per year, essentially, and trying to fit it like a puzzle. That's almost impossible. Someone's going to get the short end of the stick, right? And that might result in them burning out in a way that might not be helpful to them or to the program. And it can have that, chain reaction to other residents now picking up the workload, et cetera. So it's how do we create a fair system, right? And he brings up the point system, maybe like ICU's higher points, clinics lower points. And based off that, you don't go over a certain number of points in a quarter. And like something for us as a prelim resident is that we would do more medicine rotations to cover the categorical residents when they were on clinic. And so that would result in us burning out a little bit more during, those months where we had to cover. So I think hopefully, there's some good data that shows that program directors take this into account and can come up almost, with a standardized system for a lot of programs to use as a template.
Yeah. So I think that we're touching on the wellness aspect, and for those who are going to be in the medical field, I think that this is going to be directly beneficial to you. For anybody listening who this is not going to benefit because they're not going to be a resident or fellow anytime soon, largely what we're talking about recovery. I mean, that's his interest. He's a champion for Whoop, and we spent a lot of time talking about HRV. So we've mentioned HRV several times, but just to recap, it's basically the beat to beat variability within your heart, right? So the R to R interval that he talked about, which is kind of like this little squiggly boop, 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 a line that you'd see on TV and ER or Grey's Anatomy, whatever you watch. And the more variable it is, it's actually a better thing because it's a signal that your heart is adaptable and it can be accommodating for any type of change that can come. And if it's actually consistent, as much as we talk about being consistent being a good thing, if your heart is very, very consistent, beat to beat variability, that's not a good thing. So that's a bit counterintuitive. But more and more data that we're seeing nowadays suggests that higher HRV heart rate variability is a marker for healthier heart or more resilient autonomic tone. Is that a good way to say it?
I think so, right? That balance between the parasympathetic and sympathetic and allowing your body to distinguish between the two and allow them both to activate whenever needed. And I think the important thing here to recognize is that most of like the new wearable technology that's coming out is using HRV as a metric. I mean, this is probably the most standardized metric now that we're seeing in wearables to look at progression, right? The whole point of wearing a wearable is to see, are you getting healthier or are you progressing better? And so, Whoop uses a recovery score, a strain, respiration rate, all these different kind of things, put it together. And at the end of the month, you get a report and essentially you're looking at your HRV and seeing what are the things that are helping with your HRV. Now, essentially Aura Ring, I'm sure is kind of the same thing where you have the journal, you're looking at sleep, you're looking at your daily activity, and the output is also looking at your HRV and, hey, is it getting better? Is it getting worse? What do I need to change on the day-to-day, but also on the month-to-month or year-to-year?
For that report, you're only getting the specific variables that are influencing for the better or worse if you do the journal, right?
Yes. If you do the journal, you're just getting whatever output you are from the journal. And then it'll run regressions. So it'll tell you, like for me, blue blockers, 10% increase in my recovery. And I am likely to wear blue blockers when I do not drink alcohol, for example. And then alcohol minus like 25%, likely to do this. I will not take a magnesium supplement. So you it's nice because you learn like what goes in conjunction and how you can change also just like habit stacking in a way.
Right. It's actionable.
Right. Yeah.
Nice. Yeah, I like that a lot. So what about, we mentioned, I think one of the big barriers for this is cost, right? Again, we talked a lot about a Whoop. You're a fan of it. I mean, I am too, from exactly what I've learned and all the people who speak highly of it. And I think that just as much as I mentioned about the sticky nature of a ring for nighttime, I think during the day, I'd much rather wear a watch than a ring. It's just how I am, especially in the gym and whatnot. But again, there's a cost factor, right? There's a steep price tag depending on what version you're getting, and the newer versions are even more expensive with a monthly subscription. So if somebody can't afford that or isn't buying into it, what would you suggest for markers for recovery? How'd you go about that?
So I think, we talked about this. So one is obviously like subjective readiness, right? Waking up and, it's funny, ever since you mentioned that in that episode, I wake up and like, so before I look at my HRV of recovery, I look in my head and I'm saying, okay, right now, would I be able to kind of like bench press pretty heavy or squat pretty heavy, just like based on how I feel? And most often when I'm like, yeah, you know what? Like, I think I could do that right now. My HRV will probably be higher. Or when I'm like, I'm pretty dead, it's probably not going to happen. My HRV will be lower. So I think there is, probably a really good correlation in terms of just feeling how you're ready and really being in tune with your body. Now, obviously that takes time to be in tune with your body. We've been working out for a long time now, so we've kind of gotten used to that. But really being honest with yourself and saying, hey, how do I feel today? Do I feel ready to go crush it, be a little more intense or not, right? And then I think the other thing is just heart rate. Looking at your heart rate, I mean, that's correlated with your HRV. So when you wake up in the morning, you take your heart rate, if it's higher, if you get a trend at least for a week, you kind of know where your baseline is. If you're on the higher end of that, you're probably not as recovered. If you're on the lower end, lower heart rate, you probably are better rested. So I think that's also, that's a great surrogate, I would say.
Yeah, I agree. I was actually reviewing a podcast slash YouTube episode of Dan Pope, one of our earlier guests. He reviewed a Journal Club article, or just an article. I forget what it was, but it was recently published, looking at the effects of sleep and stress on the risk of injury in like collegiate athletes. And I found it really interesting. And I think most people, if you're interested in that kind of stuff in sports and academics and this kind of, these types of issues and interplay, then I'd highly recommend watching the entire thing. It's about 30 minutes. But if not, you can fast forward to the 27-minute mark where he gives his insight into how he practices in clinical or his clinical practice, and when he gets clients and patients to come in, and he talks about the readiness score, right? Himself, he gives himself, I think it's from a 0 to 10 or a 0 to 5. How do I feel? 0 to 10, I think he says. And he says most days he's at a 6. And, if he's at a 7 or 8, then he cannot wait to get in the gym. If he's at a 4 or 5, then he knows that he needs to dial something down, whether it's volume, whether it's, intensity, or just maybe just doing some mobility work. There are some other markers that you could look at too. You've already mentioned heart rate, but just knowing what your hydration status has been throughout the day. I mean, simple as that, right? Or throughout the week. Like for me, I'm fasting right now. And so, I'm very mindful of that when I am training during the day. I'm also eating a little bit less. So my overall caloric intake for, a prolonged period of time, for over a month time, is a little bit less. So I'm also cognizant of that. I mean, this is not going to be the time to just hit PRs in the gym, right? I'm sleep deprived. So just knowing that what's been building up over the past few days, right? Like if you know that, hey, you are in the middle of a big move across the country, or just really buying a house in this crazy market, and you're moving, maybe this is the time to try to really, go to the gym and try to PR all the time. And that's really how bad things happen. And so in the absence of HRV, which is just one marker, I think these are other things that you can really know, and they're pretty easy to track. I think just kind of take some time to kind of really reflect back and think about
well said. And I will add on, we are talking about cost here, and I think health is your greatest investment in life, right? Like without it, you can't do anything else. Mm-hmm. You're either alive or you're dead. And so like I urge people, like really look at your expenses. Like if Whoop is $30 a month, right? It is a steep price. But if there are subscriptions that you think you're probably not like worth like looking at, like whatever, if they're magazines and stuff, like I highly recommend people to like look at Oura Ring, look at Whoop, like do the research, but also just trial it out, see how you like it. I mean, you can always cancel these things. But for the most part, I've only seen people get benefit from them. At least if they're really looking to improve their health. So I will put that in there too.
Yep. Do you have to buy? Is there an upfront thing to buy the actual device, or no?
Just the monthly cost. Yeah, and then they have like a premium now for sure. But
if you cancel it, do you have to send it back?
I don't think so. But you won't get like any of the data. You probably keep like the Whoop, but you won't get like because it's all based off the app, right? So. Yeah.
Right. Right. Then it's just
you just have a black band with no interface on it. I guess it's stylish.
Yeah. Somewhat cool. Still part of the club. You act like you're part of the club.
Dude, I wanted go for it.
No, I did want to let people know we are not paid by Whoop. However, if Whoop is listening and they do want to sponsor, then we're in. We're in.
I was going to ask, man, if you're down for some bonus content. So obviously you mentioned you're fasting. For people I don't know, it's Ramadan. So if you're okay with talking about what does your like workout regimen look like right now? So obviously there's no food or water, right? From sunrise to sunset. Mm-hmm. You break your fast at night, or, before sunrise and before or after sunset is when you're eating. What are you doing in between? Like, how are you checking your hydration status? What are you doing for your workouts? How have you kind of modulated those things?
Yeah, it's a good question, man. I think, I'll try to keep it concise. I will say that one of our previous guests, Dr. Adil Khan, actually did a post on this not too long ago about what recommendations he makes for the month of Ramadan when people are fasting. And I think that Dr. John Berardi wrote something about this because he would train a lot of folks, professional athletes as well, who were fasting at the elite level. But anyways, what do I do? In terms of tracking my hydration status, it's just somewhat gross, but yeah, just looking at the color of my urine throughout the day. And I'm very cognizant of breaking my fast with a couple of glasses of water and getting plenty of water in the morning. I'm at the state where in the beginning of the month, it's always harder, right? But as the days goes on, it's a little bit easier. So you don't need as much food. And again, we have intermittent fasting has been a part of our life. So I think we can go extended periods of time without it anyway. So it's really not that really affects you as much. In terms of training, right now there are a lot of other stressors in my life, and I'm a new dad. And so I really try to get training whenever I can. What I've been trying to do lately is to do it in the evenings towards the end of my fast, and then right after I can eat, right? And that way it's quote unquote ideal, because in the post-workout I'm eating. I've also done this in the past where I've in the morning after I'm done eating and I start my fast, and I work out like 30 minutes after, because I usually have like a cup of coffee before my day starts. So I've done that in the past. I've tried every single variation. Today, interestingly, I took a little bit of nap. I took a short nap, and I woke up and I went to the gym. So it was like around 11, and I felt amazing after 10 minutes, and like felt stronger than I have in the last 2 months. So, I mean, that was interesting too. I mean, sometimes just catching up a little bit of sleep will do wonders for you. I would say, honestly, it's whenever it's easier for somebody to get it in. I've also in the past done like after breaking my fast, but then I find that it's pretty late at night when I'm working out, and I don't like to go hard before close to bed. My sleep quality suffers after that. So, really it's whenever you can get it in. Again, the important thing is, even today, I didn't try to PR. This is not the time to do that, because when you are dehydrated, when you are, in a caloric deficit for an extended period of time, the likelihood of injury is going to skyrocket, and probably not to do that. But that doesn't mean that you just completely sit on a couch. In fact, most Muslims who do fast find at the end of the month, they end up gaining weight because they're eating late at night and early in the morning, and they're really not doing anything. And they're like, oh, well, I'm fasting, so I'm not going to do anything. And then they're like, I don't know how I gained 5 pounds.
Yeah.
I do.
That's right.
So,
dude, are you doing any of the element packets in the morning? I don't know if you ran out, but
I ran out, so I need some more. We're going to need some more of those. Huge fan of the raspberry, man. Oh, God, love me some of that.
I don't think I've had that one yet. It's probably still stuck there. I've been going through the Fiesta pack, but I love it. Like, I can only imagine, even when I'm fasting and I do it, oh my God, it's unbelievable how much it actually just helps you push past kind of the brain fog and getting through it. So I can only imagine like doing that in the morning, before your fast begins, just keeping a little extra hydrated. So cool.
For sure. That's a good point. Yep. Some elements, for lack of a better word, to put into your diet. Yeah.
Awesome, man. Well, anything else?
No, man, it's been great. Guys, 3 amazing guests. Highly recommend you guys go check them out.
3 episodes.
See, 3 episodes, 2 guests, but it felt like content was 3 guests worthwhile. So go back and check that out, and it'll definitely be worth your time. So definitely enjoy that. And if you have any feedback or any both positive and negative, please shoot us an email at medredefined@gmail.com, and be sure to subscribe, review, rate,
and we're
share.
all like on all socials. So we're on YouTube. We got clips on YouTube, TikTok, LinkedIn, Twitter, Facebook, Instagram. So check out all those too. All right. All right. Thanks so much for taking the time to listen to the lessons that me and Altamash have learned. Again, we highly suggest you listen to the past 3 episodes with Dr. Harkin and Dr. Hajduczok. These 3 episodes are by far going to be some of the best episodes you will hear about the cardiovascular system, and will give you actionable tips so that you can live the best life possible. And again, we are on social media. So we are trending on TikTok, we're on YouTube, we're on LinkedIn, Facebook, and of course, Instagram. So if you want to check out short video clips of our guests talking about different topics, be sure to check any of those platforms out. And if you've been here already, you guys know the medical disclaimer. Everything in this podcast is for educational purposes only. It does not constitute the practice of medicine, and we are not providing medical advice. No physician-patient relationship is formed, and anything discussed in this podcast does not represent the views of our employers. We recommend that you seek the guidance of your personal physician regarding any specific health-related issues. Until next time.